Well, hello and welcome to everyone joining us for this X-Talks webinar. Today's talk is entitled Criticality of Stat Osmolality Testing, Identifying Toxic Alcohol Ingestion. My name is Corey Stanton and I'll be your X-Talks host for this event. Today's presentation runs for approximately 60 minutes and the webinar includes an interactive Q&A session at the end. At this point, I'd like to thank Advanced Instruments who developed the content for this presentation. Advanced Instruments is a global provider of scientific and analytical instruments for the bioprocessing and clinical industries. For more than 65 years, the company's innovations have helped organizations improve quality of results, achieve reliable outcomes, and increase workplace productivity. Clinical labs worldwide rely on Advanced Instruments' innovative solutions for delivery of accurate and timely patient results in their clinical chemistry, microbiology, and hematology labs. And now let's take a moment to meet our speaker for today's presentation. Dr. Anion Gap's academic path took him from Wheaton College in Norton, Massachusetts, where he completed his undergraduate degree, all the way to Rosalind Franklin University in Chicago for his medical school training and master's in healthcare administration and management. His residency brought him to Mountain View Hospital, part of the Sunrise Consortium in Las Vegas, where he had the privilege of serving as chief resident. Following residency, he pursued a nephrology fellowship at the University of Colorado and moved to Los Angeles in 2021 to become a full-time nephrologist with Renal Consultants Medical Group, one of the longest established practices in the San Fernando and Santa Clarita valleys. And now, without any further ado, I'd like to hand the mic over to Dr. Gap to kick off the presentation. Dr. Gap, the floor is yours.
Thank you so much, and good afternoon, everyone. Thank you, Corey, for the introduction. Thank you, Advanced Instruments, for having me on today. The agenda for today's presentation, we'll start with a couple case studies. We'll also discuss osmolarity and how it's tested. We'll move on to the osmolar gap, as well as discussing toxic alcohols, including ethylene glycol in particular. And then we'll give you a little update on our patients and discuss the necessity and importance of osmolarity testing and what the future of osmolarity testing holds from a clinical perspective. Next slide. So first, we're going to meet Mr. Thompson. Mr. Thompson's our 53-year-old male. He has a history of type 2 diabetes, and he presented to the ED with family members with complaints of vomiting and confusion. He's obtunded on exam, and he can't really participate in other further history taking. His imaging studies were otherwise negative. Nephrology was consulted for this profound anion gap metabolic acidosis that he had, a little bit of acute kidney injury, and other kind of further follow-up studies. His pertinent labs are a bicarb level of 12 millimoles per liter, which makes him pretty acidic, and an elevated serum creatinine of 2.63 milligrams per deciliter, which would be consistent with an acute kidney injury. His glucose levels are also notably elevated at 530 milligrams per deciliter. Further studies note an osmolarity of 329 milliosms per liter. His ethanol level was negative. His urine toxicology, including his aspirin and Tylenol levels, were also normal. Next slide, please. We also have Mr. Curry. I don't know if anyone's caught on. I'm a huge Golden State Warriors fan, but Mr. Curry is a 44-year-old male with a history of alcohol abuse. He presented to the ED after being found down in the garage by family members. He was found with empty bottles of vodka lying around him, as well as a few beer cans. He can't participate in any other further history as well, and ultimately he was intubated and taken to the intensive care unit for further management. His imaging studies as well were negative, and nephrology was again consulted for this profound anion gap metabolic acidosis and further studies. So what's notable for his labs, he has a serum bicarbonate level of 10 millimoles per liter, which makes him again acidic. And he has a little bump in his creatinine as well, which again would be consistent with a mild kidney injury maybe. His other studies are notable for a serum osmolarity of 329 millimoles per liter. And his ethanol level was negative, his urine tox was also negative, his aspirin and Tylenol levels were also normal. So in summary, we have two patients. They're presenting with similar changes in mental status associated with both acidotic states and a little bit of kidney injury. They both have the exact same serum osmolarity. So our patients get further worked up, and as they do, we'll kind of head back and discuss what they may or may not have been presenting with. Next slide. So what is osmolarity? To begin this discussion today, we really just need to define it. And osmolality is the osms of solute per kilo of solvent reported in osms per kilo. Osmolarity is the number of osms of a solute per liter of solution reported in milliosms or osms per liter. So for our purposes, milliosms and osmolarity and osmolarity are both measurements of solute concentration. However, they differ slightly in just how they're calculated. And when you consider the physiology of body fluids, the difference between osmolarity and osmolality is relatively negligible because body fluids are typically a dilute aqueous process or aqueous solution. So 1 liter of water weighs 1 kilo. So from a clinical perspective, these two terms can basically be interchangeable. So in our case, again, our solvent that we're talking about is blood or plasma, and the osmoles that we're talking about in our particular case are sodium, glucose, and urea. However, there might be additional osms that we need to discuss. A normal plasma osmolarity ranges from about 275 to 295 milliosms per liter. This is calculated using looking at the effective osmolarity that each solute in the plasma basically provides. And so an abnormal osmolarity levels can hint to pathological conditions like hyponatremia or hypernatremia, abnormal cholesterol levels, and toxic alcohol ingestion. The clinical implications of this are typically neurologic. You can have significant shifting in, when osmolarities change, as the brain may shrink, for example, when water wants to leave the cellular compartment to restore the intravascular osmolarity. And this can result in clinical symptoms like nausea, but if it's significant, you can also get seizures or even death. And the reason for this change is because the plasma osmolarity is dictated by the concentration gradient across the cell's membrane. So when this change occurs, you get this water shifting from a low osmolarity state to a high osmolarity state to restore the balance of the body. But this shifting is ultimately what leads to clinical symptoms. And so for this reason, in the environment of the hospital, timely and accurate diagnosis of osmolarity shifts can be important for patient care. And we'll see through these kind of testing modalities that toxic alcohol ingestion particularly can be quite life-threatening and does require some prompt intervention. Next slide. Perfect. So in the hospital setting, we have the ability to test for serum osmolarity. And what we end up doing is comparing the calculated osmolarity versus the tested osmolarity. And in doing so, we can determine if the patient has an osmolar gap. Now, this gap is the difference between measured osmolarity and calculated osmolarity, or in other words, solutes that are actually present in the patient's plasma versus solutes that we expect someone with normal physiology to have based on their blood chemistry. So an increase in the osmolar gap can stem from presence of solutes that are not included in the osmolarity calculation. So how does this equation get derived? It's through the doubling of sodium, which accounts for the chloride, and then concentrations of urea and glucose, which are measured in milligrams per deciliter, and then they converted to millimoles per liter by the conversion factor 2.8 for BUN and 18 for glucose. And so in a normal osmolar gap, you may have it about less than 10 milliosms per liter. And this helps take into account for kind of lab discrepancies or changes in the sodium and BUN or even alcohol levels that the patient may have. An elevated osmolar gap would then suggest that there's a presence of some unmeasured osmotically active substance, such as toxic alcohol. So the plasma osmolar gap cannot be distinguished. It cannot distinguish amongst ethanol and isopropyl alcohol or ethylene glycol. However, it can measure the difference between the calculated and the measured. So if you can see from the picture on the right, what we do in the hospital is measure the osmolarity, and we get the total osmolarity there. And through what we expect the patient to have, we can calculate the osmolarity. And if there is a significant difference, that would take into account for something there that we essentially cannot take into account or we cannot calculate, not because we can't necessarily calculate it, but because we don't have the means to calculate it in the hospital acutely. Next slide, please. So toxic alcohols are kind of organic compounds that contain one or more hydroxyl groups. and they're not really designated for human consumption. They're used as solvents, preservatives, compounds, sometimes precursors to other compounds. The common, most well-known ones are methanol and ethylene glycol. Methanol and ethylene glycol are used in high concentrations for automotive coolants, for example, or antifreeze, used as de-icing solutions, windshield wiper solutions, cleaners, and other products in the kind of in industry. Curiously, at the start of the COVID pandemic, there was a bit of an outbreak in methanol poisoning from ingestion from hand sanitizers. And there were other spikes in toxic alcohols during this period of time as it became harder for people who were reliant on alcohol, normal alcohol that we would drink, to acquire that kind of alcohol. And so if they became dependent or they heavily abused alcohol, they searched for other ways to kind of get that alcohol buzz, and that's where these toxic alcohols come in. So these alcohols can be ingested on accident. They are commonly in unsecured places like under the sink or in the garage, and oftentimes they're kind of easily accessible to children and pets. They do have a sweet taste to them, and that sometimes doesn't dissuade people from consuming them. And then for those who may purposefully take them, they can be a strangely attractive, low-cost fix for patients who have alcohol abuse, as they do have that alcohol-like sedative state that they give. So initially, these alcohols do cause an intoxicated state, and that alcohol itself is actually not toxic to the body. What we'll talk about in a bit is essentially these metabolites of these alcohols are then responsible for the toxic effect of the body. So for example, ethanol converts to acetaldehyde through alcohol dehydrogenase, and then is converted to acetic acid by the enzyme aldehyde dehydrogenase, and that then gets broken down to basically water and carbon dioxide. In the Asian population in particular, many lack that aldehyde dehydrogenase enzyme, which is then accumulates acetaldehyde, which is then responsible for that flushing of the skin that they can get. Next slide, please. So now ethylene glycol, this is probably one of the more known toxic alcohols. It was first synthesized in the mid-1800s. It was used in the early 1900s, I think first to make dynamite. Today, again, precursors for even plastic bottles for soda consumption. It can be used as a drying agent given its high boiling point. And so clinically, the most common one that we would then see is its association with antifreeze. So ethylene glycol does give you a buzz. It is an alcohol after all. Ethylene glycol is not in itself harmful as a parent compound. However, the byproduct of its metabolism is. So ethylene glycol is then metabolized again by alcohol dehydrogenase into glycoaldehyde, and that gets further metabolized with aldehyde dehydrogenase into glycolic acid and ultimately oxalic acid. The glycolic acid is kind of what's the one that kind of contributes to the metabolic acidosis that the patients would then present with. While the oxalic acid can form into calcium oxalate crystals, and these crystals essentially clog up the kidney, and that's what can lead to renal failure. The initial symptoms, patients may present with that same buzz sensation that they would get from typical alcohol, but over time, they may present with symptoms like flank pain, hematuria, and oliguria specific to ethylene glycol. So where have we seen this in our history? In 1937, there was the S.E. Massengill Company. This is a Tennessee drug company that manufactured antibiotics. Sulfanilamide was the antibiotic of choice at the time, and what they wanted to do was dissolve it into a liquid form, and they used diethylene glycol to do this. Now, at the time, the Food and Drug laws didn't really require toxicological analysis before releasing it for sale. Unfortunately, 105 people died in about 15 states, but that led to the Federal Food, Drug, and Cosmetic Act of 1938, where stricter laws came into place evaluating what essentially is made and distributed in this way. So for many of you, you may think that 1937, that's so long ago, but there are still instances of essentially these toxic alcohol ingestions, and unfortunately, some of these happen in children. So in 2022, in Uzbekistan, the health ministry reported there were about 18 children who died after drinking cough syrup that was manufactured by Marion Biotech, an Indian drug company. When they did the studies, they essentially found that the medicine that they made contained ethylene glycol. So 21 children, 15 of them, which were under the age of 3, essentially got treated for acute kidney failure due to this cough syrup. Around the same time, World Health Organization made an alert that there was another cough syrup that led to the death of 66 children in Gambia. And again, these tests, the tests on the cough syrup samples show that they contain an unacceptable amount of toxic substance, particularly diethylene glycol and ethylene glycol. And so this is not something that is so remote in our history. It is something that we know can accidentally happen due to even cough syrup that we give children. And then certainly the concern is the abundance of availability for some of these compounds in certain things such as antifreeze and car fluid. Next slide, please. So osmolarity testing does play a pretty critical role in diagnosis of toxic alcohol ingestion, and this is how it happens. Patients will present with symptoms such as altered mental status, acidosis, visual disturbance, or even renal failure. And some of these symptoms then get flagged, particularly if the patients have a history, for example, of alcohol use or possible toxic alcohol ingestion. Now, there are times where it's possible where you can ask the patient, did you take anything from the garage or did you drink anything under the sink? However, as we can see from our two case patients, Mr. Thompson and Mr. Curry, both of them presented with cognitive impairment. And so this makes this process somewhat challenging to do. And oftentimes, family members are unable to kind of explain what's been happening to the patient. And even if the patient is able to tell you a history, sometimes they're even unwilling to, or again, unable to do so. So for those patients that were concerned about toxic alcohol ingestion, we can check a blood sample, and that can be taken to measure their serum osmolarity, and then ultimately their osmolar gap can then be calculated. Like I mentioned before, the quickest and most least invasive way to do this, this is the quickest and least invasive way to do this, to check for toxic alcohols, and that would then allow us to have some kind of timely intervention to treat this. Remember, an elevated osmolar gap indicates that there's a presence of an unmeasured substance, which in this kind of clinical presentation would suggest then toxic alcohol ingestion. The measurement of serum methanol or ethylene glycol concentration is usually performed. However, such testing is not always available in-house at most hospitals. And a lot of these labs then become send-out labs to big tertiary centers or even the NIH. And it doesn't really allow a good window of time to get results back to clinically use that for decision-making of a patient's treatment plan. So the current kind of teaching and guidelines is, if the suspicion is high enough and you have an elevated osmolar gap, you would send out the labs for ethylene glycol or diethylene glycol, but you would start treating the patient before those labs come back. Now, to be certain, these treatment modalities require extensive hospital stays in the intensive care unit. They can require antidotes like fomepizole, ethanol in some patients, and then oftentimes hemodialysis to help remove some of these toxins in addition to just general supportive care. So one of the challenges, though, of the osmolar gap in itself is it's not sufficient enough, it's not sensitive enough all the time to exclude small quantities of ingestion. So remember, we kind of use 10 milliosms per liter as our general guideline and a cutoff of normal. So if someone has a anion gap less than 10, the practice as of now is essentially, well, you ruled out toxic alcohols. The one wiggle with that is, unfortunately, if a patient ingests a very small amount of toxic alcohol, they may not generate an osmolar gap big enough to be sensitive with just osmolarity testing. So it is important to do both. You want to check their osmolarity and see if they have an osmolar gap, but it is just as important to send off the ethylene glycol and diethylene glycol levels and use that as a confirmatory test and not wait necessarily for those to come back before you treat. And a lot of that is based on clinical suspicion. So with that said, timing for testing is quite important. As I mentioned in later slides, the test can be done too soon, meaning if the patient ingests a toxic alcohol and you test them right away, they may not generate enough osmolar gap at that time. However, early detection is critical because the sooner that we can test these patients, the better our data will be and the better we can trend to see if the osmolar gap goes down and the anion gap goes up. Now remember, the parent compound itself, which is the alcohol, gets metabolized into the toxic compound. And so the parent compound is actually what's responsible for the osmolar gap, not the toxic metabolites. They do not contribute to the osmolar gap at all. And so you'll see in the subsequent slide, once the parent compound gets metabolized, the patient will start to see the repercussions of that toxic compound. Next slide, please. And so I believe we have another poll question.
Yes, that's right. We do have our second and final interactive poll question for the audience today. Previously, we asked you about the type of osmolality available, calculated, measured. This time, we'd like to know, does your laboratory send out measured osmolality testing? And we're just simply looking for a yes or a no response. Again, the question is, does your laboratory send out measured osmolality testing? And you can vote for yes or you can vote for no. And as we did before, I appreciate all the votes who have come in so far. I'll leave the poll open a little while longer to allow the majority of the audience to get their votes in. Again, simply just looking to get a sense of our audience members here, whether or not your lab sends out measured osmolality testing. And we're just looking for a yes or a no response. If you haven't had a chance to vote yet, I'll leave the poll open for another 10 seconds, and I'm going to go ahead and close the poll. Okay, great. Let's go ahead and close the poll now and just take a quick peek at those results. So interesting division here again. Pretty strong majority here, 78% saying no, laboratory does not send out measured osmolality testing, but we do have 22% coming in at yes. So definitely, a significant majority there, no sending out measured osmolality testing. Back to you, Dr. Gower.
So regarding the poll, I think the most concerning part is the 22% part. Now, as I mentioned in the previous slides, if you look at the diagram that I have here, as the osmolar gap closes, that's the time that you need to test. And so a reminder again, the toxin metabolites are acidic, and that's why we see the anion gap go up. But once the parent compound is fully metabolized into the toxic metabolites, then realistically, it becomes very hard to treat, even with medications like fomepizole. Fomepizole specifically inhibits the alcohol dehydrogenase and prevents the parent compound from being metabolized into the toxic component. Now, in some cases, they've given ethanol to patients and have them drink beers in the hospital in order to suppress and turn that enzyme off. Once these toxic metabolites are formed, however, in the case of, let's say, ethylene glycol, you can really start to see that renal failure kick in. The reality is that toxic alcohol ingestion is extremely fatal, and the window to treat is relatively small. If in a perfect scenario, if money was no issue, every hospital will have in-house osmolarity testing, as well as in-house ethylene glycol and methanol and diethylene glycol testing, all in-house where you can get. Now, in some places, this is the case. If you have a big tertiary center, sometimes big universities, they will have ethylene glycol or methanol in-house, and they will also have osmolarity in-house. However, the truth is that's not realistic, nor is it financially feasible for community hospitals to have. And so while the send out for a specific parent compound may be appropriate, the ability for the hospital to be able to calculate an osmolar gap becomes that much more important. If you can't calculate an osmolar gap and get timely results, then I think you're really increasing the mortality in these patients. The alternative is, if you can't test for it, but your clinical suspicion is high enough, you could potentially drive up the cost of the institution as well, because you don't have data or clinical evidence that the patient necessarily has some kind of toxic alcohol ingestion. But I think you then get pressed to treating them with fomepizole and even hemodialysis really until your send-out labs come back. Now, again, I don't know the costs of all of this, but I suspect that's probably much more costly for a hospital to have than rapid in-house testing, at least osmolarity studies. And so for this reason, I think as hospitals continue to advance in technology and diagnostic capabilities, the role of osmolarity testing remains quite indispensable and really safeguards patients from potential bad outcomes, particularly in patients where the clinical suspicion is that high. Next slide, please. So in this case, our case study, let's discuss Mr. Thompson. So Mr. Thompson was our 53-year-old male with a history of diabetes who presented with altered mental status. So our patient did have an anion gap metabolic acidosis. However, he did not have an osmolar gap. And so if we plug and chug, he actually had a serum osmolarity of 329, and that was his calculated one, which then matched his measured one. And so even though he did not have an anion gap, he did have an anion gap and he was without an osmolar gap, the assumption is that he was likely from acidic with a high glucose level from diabetic ketoacidosis. And this is notable because his glucose level is 530. So this patient can be treated safely on an insulin drip and given some fluids, and he can safely get discharged within a few days once his diabetic ketoacidosis resolves. Next slide, please. Now, Mr. Curry, on the other hand, he demonstrated both an anion gap metabolic acidosis as well as an osmolar gap. And so his calculated osmolarity was 292, but his measured osmolarity was 329. So this would be notable for a gap of 37. So that's 37 milliosms per liter of things that we did not expect to be there with normal physiology. So given his history of alcohol use, given his history of being found in the garage with a high clinical suspicion, even if we don't have in-house ethylene glycol and diethylene glycol testing, the appropriate thing to do then is to treat this patient as if he does. And so in his particular case, given his progressively worsened status, as well as the concern for his kidney function, he would be given a dose of fomepizole and essentially used as an antidote for methanol or ethylene glycol. And then he would then get started on hemodialysis. And that's what happened with this patient. The patient was started on hemodialysis to clear the suspected ethylene glycol toxicity. And then 3 or 4 days later, the ethylene glycol level came back positive. And so the team was reassured that they did the right thing by not treating this in any other way, preemptively treating this patient. And ultimately, the distinguishing thing between these two patients was the osmolar gap. Next slide. So the future of osmolarity. The reality is we don't have a rapid or cost-effective way to test for all toxic alcohols. Like I mentioned, big tertiary centers and universities may have some of these things. However, even big centers may not have tests for diethylene glycol. And so the last time I checked and I was concerned for a diethylene glycol patient, the only send-out place I would take it was the NIH. And so if this is the reality of medicine and not the ideal way of medicine being practiced, but if this is the reality, then we have to rely on the osmolar gap as the only cost-effective and the only efficient way we can determine if there is a presence of uncalculated, unmeasured osmolarity that may be contributing to the patient's metabolic profile. And so while we focus this conversation really on toxic alcohols, there are quite a few other disease processes such as like hyponatremia or even hypernatremia where osmolarity testing becomes quite important. And so the utility of having osmolarity testing in the hospital it not only is a safeguard for patients who then come in with concern for toxic alcohol ingestion, but the ability to use the same studies to process and decipher patients who may have hyponatremia, hypernatremia, hyperlipidemia even, in addition, makes this testing that much more important.
Dr. Gower, this one's for you. You mentioned the toxic alcohol panel taking 5 days to get back, and I know you kind of covered this in your presentation, but maybe we could kind of just give a little refresher on what tests are currently available to test directly for toxic alcohols.
So it is institutionally based. I trained at University of Colorado, and there we had ethylene glycol, methanol, to readily be tested. And so the turnaround time was within a couple hours. Osmolarity testing was also in-house, and that was, half an hour or so. So in these kind of big tertiary, big university settings, it's fantastic. They have what they need. Now, some of the stuff, diethylene glycol in particular, was not available. And last year when I had a suspected patient of diethylene glycol toxicity, we couldn't find a laboratory who would then test for it. And so we contacted the NIH, and they had a way to test it, but it would have been about a 10-day turnaround time. And obviously from a clinical perspective, that's just way too late. And so there are tests for toxic alcohols directly. Now, keep in mind, they're testing for the parent compound. And so if you test someone 3 days after their presentation, and that parent compound then gets metabolized into their toxic compound, the parent compound might not be there anymore. So you may get a false, it's a appropriately negative, however false test, because the patient may have already metabolized that parent compound there. So some places do have it, but I can assure you that the majority of community hospitals probably do not have this testing in-house. And so they heavily do rely on osmolarity testing in order to determine, one, if the patient has an osmolar gap, and therefore a substance that we physiologically do not expect to be present in the patient's body.
Great, excellent. Thank you for that, Dr. Gower. Another question here that's come in from the audience, and again, sort of covered it during the presentation, but perhaps we could have a little refresher on just why is it so important to have that faster turnaround time for management of patients with hyponatremia?
Yeah, so hyponatremia is a kind of the other way to use osmolarity testing. And so what we look for in hyponatremic patients in particular is this a true hyponatremia? And so in a patient who, for example, does come in with significantly elevated glucose levels, particularly, let's say, if someone comes in with diabetic ketoacidosis, it's not uncommon for us to see that their sodium levels are actually hyponatremic. They're very low. It's a false low, and the reason is the patients are actually normal osmolar, or even sometimes hyperosmolar, because of the elevated glucose level that they carry. And so the benefit of using osmolarity testing for hyponatremia is really to determine, is this a real hyponatremia or not? Now, in addition to hyponatremia, there's a utility for hypernatremia in addition. Now, hypernatremia, we already know that the patient, in terms of their plasma, will be hyperosmolar, going to be hypertonic, a hypertonic hypernatremia. The kind of cool part is knowing that you can check a urine osmolarity. You can determine, okay, well, is this patient doing, or is the kidney doing the appropriate thing in holding on to water? Now, this gets into a little more physiology, but if the patient is hypernatremic, so they have a high, let's say, salt load in their body, their total body salt is higher than physiologically appropriate, you would expect the kidney to then compensate by holding on to water as much as it could. And so if you were to check a urine osmolarity, you'd expect it to be very, very high. Now, if it's not, if the urine osmolarity is low, that implies that the urine is very dilute. If the urine's dilute, that's physiologically not what the kidney should be doing. If the patient's hypernatremic, you'd expect them to hold on to water. And if they're losing water, there is a disease process called diabetes insipidus, where the patient is actually peeing out water inappropriately. And the way to test for that really is the urine osmolarity. And so there is utilities for, we really focus on toxic alcohols, but the utility of osmolarity testing, I think, goes a little bit further. We're talking about hyponatremia, hypernatremia, and toxic alcohols. That kind of testing is important, essentially, to appropriately diagnose a patient and then appropriately treat them for their pathology.
This audience member is asking about if we need to send out a sample, how long would that sample remain stable in order to give a correct measured Osmo reading? Like what is that? I'm sure it differs a little bit, but is there kind of a ballpark?
I don't think I have a good answer for that. I mean, the majority of the time when a hospital does send out a sample, when we're talking about, toxic alcohols, for example, the sample is usually shipped overnight. And obviously from a clinical perspective, you want that to happen right away, not necessarily because I would be worried about the sample degrading, but I want to know what to clinically do with this patient who may be waiting on that sample to come back. I don't have a good answer if the sample necessarily would degrade. That's a good question. I don't have a good answer for that one.